Good afternoon. Thank you so much for being here so late in the afternoon. I know on Sunday that we are running late, so I'll try to be very brief. I very much appreciate everyone to be here. I'm a full-time employee of Fibrogen. My name is Ewa Carrier. I'm Executive Director of Clinical Development. And I need to mention for disclosures that efficacy and safety of FG3019 was not established in humans as yet. However, I want to introduce you to my company and also to this new drug that we are testing in non-ambulatory children with DMD. So these are the points I will briefly discuss. Introduction to Fibrogen, which is a new on the DMD to DMD. Just mention on unmet need in DMD. Some introduction to FG3019. Brief overview of preclinical data. The hypothesis and rationale for clinical development. And some protocol highlights and information for you if you have interest. Fibrogen is a company, public company in San Francisco. It was founded in 1994, so it's 2 decades around. It focuses on biology of fibrosis in different organs, and now including DMD, and also, long name, hypoxia-inducible factor is tested in anemia. And FG3019, it's a novel human monoclonal antibody, a pure protein, that is presently tested in 3 indications: DMD, non-ambulatory, idiopathic pulmonary fibrosis, and pancreatic cancer. And this is because this mechanism of anti-fibrosis is universal. Whenever there's fibrosis, it appears that this compound may actually have some biological function. So, just to give you just overview, yesterday and today we discussed that there is a need for disease-modifying therapies in DMD. That means that we would like to slow, stop, or perhaps even reverse muscle degeneration in DMD. The current therapies, the exon-skipping therapies, cover about 1/3 or less of DMD patients. And we have some animal data in MDX mouse model showing us that this drug, FG3019, antifibrotic, may actually work. Before I show you the data, I just want to give you an overview of this compound. It's a human monoclonal antibody. We tested this in already 400, a little bit more than 400 adult patients. With these 400 patients, we did not detect any safety signals so far. Some patients received it for more than 2 years. We have established clinical proof of concept in 2 indications: pancreatic cancer, where there seems to be positive impact on improved survival, and pulmonary fibrosis, where there is a fibrotic changes in the lungs. If you have interest in the pulmonary fibrosis impact of FG3019, we have reprints of the publication in the Fibrogen booth, which is open. So, what is the role of FG3019 in DMD? We've already reviewed it in details that there is a regeneration where the normal muscles are formed, but in DMD, when there is less dystrophin or no dystrophin is produced, there is a chronic inflammation, transformation, myofibroblast formation, and fibrosis. So this box at the bottom on the right shows fibrosis. Once there is fibrosis replacement of the muscle function, this is where you can see decline in the motor function when the children don't walk as fast and don't walk with time. So Having said that, I would like to say that my hypothesis for the testing in clinical trial is that slowing or reversing this fibrotic process may allow muscle regeneration and improvement of function. It's a very simple hypothesis that's being tested. And again, this is the data from humans showing that you have increased collagen formation and fibronectin deposition in the muscle of DMD patients. And in those patients, CTGF, connective tissue growth factor, is increased. And this factor, this protein, drives fibrosis. So FG3019, it's a human monoclonal antibody against this protein. It will neutralize this protein and perhaps decrease fibrotic process. So that's the basis for mechanism of action of this new compound in the DMD that's being tested. So I've already alluded, and this is just a summary to show you that in this process to the right, when there is chronic inflammation and elevated CTGF, the FG3019 will neutralize CTGF, decrease fibrosis, and perhaps increase regeneration of muscles. And indeed, in MDX mouse model, we have shown on the left, the pictures on the left is control, the pictures on the right is use of FG3019 in this mouse. The red color at the bottom is collagen and fibronectin is in the middle, and you can see actually collagen is green and fibronectin is red. Then on the right column, after we give to the mice FG3019, the fibronectin and collagen production is decreased. Now, I've already mentioned that there is an improvement in lung fibrosis. So on the left, there is a mouse with irrigated lungs, and you can see that after 2 weeks of FG3019 on the lung CT, you can see there is improvement in fibrosis. These are two boxes, and this box on the right. On the right side of the slide, these are idiopathic pulmonary fibrosis patients that were treated with FG3019. And we've noticed that 35% had stable or improved fibrosis and improved lung function. And if you want to know details, again, we have a reprint of the manuscript for you at Fibrogen books, so please come by. Gustavo is there, and he will be very happy to share this paper with you. So we hope to have similar effect in the fibrosis in the muscle of DMD patients. So just to summarize, the CTGF is a protein that drives fibrosis. We have shown in MDX mouse model that when FG3019 is given, there is less fibrosis and improved function. And our hypothesis is that inhibition of fibrosis in DMD, or inhibition of CTGF, should I say, will improve function, muscle function, and perhaps heart function, which we also test in this trial. This trial that I will just briefly describe to you is in non-ambulatory children. We wanted to establish safety profile in these children before we go to ambulatory and look for some efficacy signal in these children. The disease is very advanced. So this is the protocol. The objective is to evaluate safety, efficacy signal, pharmacokinetics, and dynamics of FG3019 in non-ambulatory boys with DMD age 12 years and older, 12, 2. The primary efficacy endpoint will be a change in pulmonary function. We think that if we can improve function of intercostal and diaphragm muscle in those children, we can see the readout in pulmonary function tests, such as forced vital capacity and other measures. But we also will look in the functions in upper muscles, grip, pinch, broke, and use MRI of the biceps and the heart, because those children, they have already changes in the heart. And you've heard during this talk that there's a lot of work on the quantitative MRI, and we believe that if we see changes, we will be able to read that there is a biological activity of FG3019 in the muscles and in the heart. And of course, we'll test changes in quality of life, which we consider very important. These are the key inclusion criteria. I'm not going to go in details. Many of them are very standard. But this will be children 12 years of age in which diagnosis of DMD was established. And we would like to document decline in pulmonary function by more equal 5% in 2 readings over 18 months period. So this is very important to us. We also want these children to be on a stable dose of steroids for a minimum of 6 months, which I think every trial recommended. These are the exclusion criteria. So we will exclude children that were more than 16 hours on continuous ventilation, the children who may have a back surgery within 1 year, who may have uncontrolled heart disease, and who were in the wheelchair for more than 5 years. And this is because we would like to have somewhat homogeneous patient population to be able to have the efficacy readout that I have already mentioned to you. These are the centers that already are open and accruing. So we have 5 centers and 4 pending that will open soon. We will be informing our investigators about other centers. So if the center is open close to you, the investigators may refer you to the closest center. So you don't need to travel that much. And we can provide travel support. So please inquire with the investigator. If you have questions or want more detailed information, we have a booth, as I mentioned. Gustavo contact is in brown color. He's very responsive. He'll send you an email, he'll call you, he'll talk to you. He's very passionate about the trial, as we all are. And as I promised, it's very short, but before I end, I wanted to thank all of you. This was a very unique conference with patients, with families, with Pat Furlow, with PPMD, with everybody, clinicians, academicians, and industry. It's very unique, it's very beautiful, and I really appreciate being here. Again, I very much appreciate the invitation and participation of the investigators. Thank you very much.